Next, we will hear from Angela Weeks, Director of the National Center for Youth with Diverse Sexual Orientation, Gender Identity, and Expression. We're so grateful she's with us today to share her perspective and expertise. Angela?
Yes, thank you for having me. I'm really glad to be here today. And I will go ahead and jump into my slides. So next slide. I'll be talking about LGBTQ populations. Our center focuses on LGBTQ people across the lifespan. And so I will talk a little bit about some of the unique experiences that LGBTQ people have that will require some special considerations for behavioral health care. Next slide. This is our Center of Excellence on LGBTQ plus behavioral health equity. This is funded by SAMHSA, and I'll talk a little bit at the end of the presentation about some of the resources we have that we can share with you. Next slide. So if you haven't already worked with this population very closely, it's important to know that the population experiences unique vulnerabilities directly related to hostility, violence, and rejecting behaviors. Specifically because of their sexual orientation, gender identity, or gender expression. And I'll talk a little bit about those on the next slide. So risk factors with this population are a lack of family acceptance and support. And in some cases, the LGBTQ person might lose their family entirely or be sort of forced out of their community. If they're living in a space that's very anti-LGBTQ, they may feel pressure or even a need to move to another location. And so there's a lot of loss that comes with that. High rates of bullying, harassment, and violence with this population are still very problematic. Bullying LGBTQ related bullying is the #1 bullying, sort of topic or bucket that young people experience. And in fact, over 90% of high school students report that they hear anti-LGBTQ stuff at school on the regular. And then as far as violence and harassment, it's prevalent. One example is that Black trans women, or really trans women of color, are one of the most targeted groups in the US for hate crimes. There's also a lack of visible possibility models. So in other words, who around me is LGBTQ that's living a healthy, open life. So there's a lack of those models around, lack of social programs, limited access to affirming care. There's a lot of stigma, of course, associated with LGBTQ identities that impact daily life. There's internalized biases as a result of all of these experiences, economic hardship due to discrimination, which could be, inability to access affirming workplaces. It could be being fired because of an LGBTQ identity. And still in the United States, there are a lot of states that don't offer protections for people who identify as LGBTQ from workplace harassment or even losing your job or housing. And then there's historical trauma and anti-LGBTQ legislation to consider as well. So if you're serving older LGBTQ adults, they've lived through a time where LGBTQ identities were criminalized, where they were not able to build families and even discouraged from being around children. They were not able to marry, in many cases lost lots of family, lost friends and entire communities to the AIDS epidemic, which was an epidemic no one was rushing to help with until it started affecting straight and cis populations. And so there's a lot of historical trauma there that impacts even now the mental health of LGBTQ older adults. And right now, as we see a really huge uptake of anti-LGBTQ legislation across the country, there have been somewhere around 400 bills that have either been proposed, debated, some of them have passed. That national debate about LGBTQ rights is also very stressful on the population. And so all of this leads to high rates of isolation, depression, anxiety, minority stress, and other mental health outcomes. Next slide. There are protective factors. Easy access to affirming care is one of them. High self-esteem, so if there are programs or therapeutic practices that can help build self-esteem. Learning and applying coping skills, so there are several therapeutic programs that do that. Supportive family, and this could be family of choice, teachers, mentors, connection to other LGBTQ people, having positive role models, or even if that person is able to be a role model themselves, hope of transitioning to one's affirmed gender, supportive communities, which includes supportive churches, schools, places of employment, and positive reactions when someone comes out or discloses their identity. Next slide. There are gaps in behavioral health care. There's a gap of affirming and competent providers. So I wish I had a map, as shown by earlier presenters, that would show how many LGBTQ competent and affirming providers are across the country. It's very few, and there are many counties that don't have anyone. In some cases, someone would have to travel hours to get to a provider that is affirming of an LGBTQ identity. And usually it's concentrated in like the metropolitan area of the state. There is an incredible lack of tailored programming and services. So all of those risk factors I just mentioned, call for some tailored and culturally specific programming for the population that discusses the coming out process, loss of family, loss of community. And there's really virtually hardly anything out there. There's a handful of programs that have been developed, but very few behavioral health providers have actually taken those programs and implemented them in their practices. There's also hardly any intentional work with families of LGBTQ people. And so oftentimes LGBTQ people are told to, cut off their families if they're not being accepting, move to a different town, move to the big city, or find a chosen family. But little behavioral health work is actually done with the families of LGBTQ people to try to help get them to move along to a place of more acceptance and love. And there are programs for that too. They're just not adopted very often by behavioral health provider agencies. There's also a lack of consistently collected health data for the population. And I would be remiss if I didn't mention again that, anti-LGBTQ environments increase the risk of negative health outcomes for this population. And as we see anti-LGBTQ legislation being continuously proposed, it also makes it increasingly more difficult for LGBTQ people, particularly trans people, to feel safe disclosing their identities and needs to their providers. Next slide. There's a couple of lessons that we've learned in evaluating several workforce development initiatives. One is that training is a necessary first step, but it can't be the last step. It can't be the only step. We've learned that if you have a training, you will most likely lose any gains you made around attitudes and behaviors about 3 to 6 months after the training. So there's a short window after a training where you want to get in and you want to provide coaching and reflective supervision and follow-up content to help people retain the information and apply it to practice settings. So training can't be the only thing. As I said, consistent coaching and reflective supervision really are what it's going to take to help people change their behaviors towards this population. We've also learned through evaluation that virtual live training has a similar impact as in-person training, which is great news for those who love virtual trainings. Self-paced e-learnings that people do on their own also have gains across all areas that we've measured, though not as many gains as the live training, either virtually or in person. And then many providers avoid conversations about LGBTQ identity because they're worried that they're going to make a mistake or that it's going to feel awkward to have these conversations. And so we've really learned the only way to overcome this is to practice. And so people need opportunities to practice through coaching or role plays to really get beyond that fear. Next slide. We also evaluated some virtual groups. And if you want more information on virtual groups for this population, I've included 2 links in the slide. But what we found was that virtual clinical groups had similar outcomes to the in-person clinical groups, which is great news. We also found out this was only possible because of the pandemic, but we were able to compare in-person and virtual of the same programs. And we found that there were higher retention among members, both families and LGBTQ young people. Also, being virtual enabled the group members to use a different name or a photo to protect their own privacy. So if they were worried about someone finding out that they were LGBTQ, that just increased their access to be able to participate in virtual sessions. And then the program reach really extended into rural communities, which we hadn't been able to reach before. So those were some of the benefits of our virtual work. Next slide. And I just want to give a shout out to some of the resources that are available to everyone here on the call. Our Center of Excellence provides free access to experts, updated resources. We have rapid technical assistance if you were to request TA. We have loads of free professional development in the form of live sessions, recorded sessions, and also self-paced e-learnings. And we provide opportunities for peer-to-peer learning, and you can get all of that through the Center of Excellence site. Next slide. We also have a national SOGI center, which is a clearinghouse and repository of hundreds of resources across the country. And so there's really a lot to check out there. And then if you don't know where to look or where to get resources, you can always contact us and we can connect you. So that concludes my part of the presentation, and I'm going to pass it on to the next presenter.
Thank you so much, Angela, for sharing all that information and resources for how we can support behavioral health for LGBTQ individuals.